back, everyone. I hope you had a nice lunch, and we're getting ready to start the afternoon session. My name's Lisa. I'm a genetic counselor here, and I am excited to introduce two wonderful genetic counselors. So Dr. Cami Schneider, who is a genetic counselor at Children's and works in the oncology setting and does a lot with polyposis and children as well, and Michelle Springer, who's a genetic counselor with the Hereditary Cancer Clinic here. And they are going to talk about What About the Children, Part 2. Cami spoke at our last symposium a couple of years ago, and we are actually recording today's talks, and we also have recordings from our previous symposium. So knowing that maybe almost 80% of you are new this year, that's an option too. If you're wanting even more, we have that recording as well. And another just quick reminder is we'd love to hear your feedback. So on the back of your badges, there's a QR code. You know, what are things that you liked about today's symposium? What are other things you want to hear about? We use that information to really inform upcoming meetings. So thank you to Cami and Michelle.
Thank you, Lisa. And speaking of feedback, this is why Cami is back with us again today. I would highly recommend everybody watch the first talk that she did at our symposium in 2023. A lot of great information, and we got a lot of feedback. We want to hear more from her. We want to hear more about testing children and considerations and things like that. So I'm truly just along for the ride. So I'm going to kind of be asking Cami some questions. And really, we want this session to be more engaging and interactive. So we'll kind of start with a few questions that we get a lot from all of you in clinic. So kind of the big things that we think about with testing kids. But then we'd really like to open it up and hear more from you guys in terms of what questions do you have, because Cami is such an incredible resource for all of us. So I guess my first question then, we think of Lynch syndrome as an adult onset condition. And, you know, I think we all talk about, okay, when do we test the kids? And we often hear this age of 18, you know, when they reach adulthood, we'll test. I would love to get your thoughts on kind of where we're at right now with that and how you approach this with your families.
Great. Thanks, Michelle. Thanks for coming on the ride with me. And thank you all for being here. And like Michelle said, I gave a lot of the background information a couple of years ago. So I do hope that everyone will go back and look at that if you were not here last time. I do want to start with just talking about the term adult onset, because Lynch syndrome is not an adult onset condition. The surveillance and management begins in adulthood, where medical intervention is required or recommended. But we do know that children do have some risks in childhood. It's just that we don't do anything different in childhood other than signs and symptoms awareness and education. So we don't need to do genetic testing in order to be aware and educated and bring attention to the doctor if there's signs or symptoms. So because of the lack of medical intervention, it's ethically recommended to wait till adulthood. So it's not like it's a magic age at 18. It's that ethically at 18, you can make an independent adult decision about whether you want to know the information from genetic testing or not. Some people in the genetics world, knowing that they're at 50% risk for a condition, can say, I know I'm at 50% risk. I know that I need to start colon screening. If I have Lynch syndrome, I don't want to know. So I'm just going to do the screening so I know I'm keeping myself healthy, and then I don't have to know my genetic status. So when you test a child, you're taking away their right to not know if they don't want to know as an adult. We don't know how people are going to feel until they reach adulthood. And so that's where those ethical recommendations come from. Now, I work in pediatrics, so I see lots of people for Lynch syndrome. So if you don't test in childhood? Why am I seeing lots of people for Lynch syndrome? And it's because there's a lot of reasons that we might consider the impacts of Lynch syndrome in childhood or testing children. Those ethical recommendations are kind of top down. Someone said patient autonomy is the most important thing, so we're not going to test until someone's over 18. But there's a lot of good arguments for why someone might want to test their children. Living with uncertainty can be just as psychologically harmful as knowing your status. So just depending on the person and the family and how they value information, those things can really be family specific. The maturity of the child and how much the child wants the testing. I think it depends on how old the child is and how much they're part of the decision making. So there's a lot of things that factor in to those decisions. There's also the issue of what I mentioned before about this not just being an adult onset condition. We're trying to change phrasing to a condition with adult management only. That there are risks for things like brain tumors in a minority of people with Lynch syndrome. And so it's important to know what the symptoms and signs are of things like brain tumors, or in families where there's early onset colon cancer, like before 25, where we might want to start screening before someone's 18 with colonoscopies. Or if you've got symptoms of blood in the stool, some of the other speakers talked about, we don't want to ignore that in someone who's a teenager, regardless of if they've had genetic testing or not. So for all those reasons, those are some of the things we think about.
So piggybacking off of that, what would you say are some of the emotional concerns with testing children? Obviously, there's no one-size-fits-all approach. And do you feel like there are concerns with delaying that testing?
Great question, Michelle. So a lot of the emotional things come down to, I usually tell my patients, like, some people feel like knowledge is power. Some people feel like ignorance is bliss. And there's a lot of values that come along with that. When we do genetic testing and we are identified to either have a risk or we are sitting with the uncertainty of not knowing what our status is, a lot of the feelings that come up a lot are anxiety. So you have to think about, are you somebody that is super anxious and this is going to cause more anxiety to know that you're at risk? Or are you so anxious that you can't sleep at night until you know your status? And maybe there's a huge relief to know that you don't have to worry about it anymore if you test negative. There's also the aspects of kind of guilt and shame kind of feelings. We cannot control what genes we get or what genes we pass on. I'll say that again. We cannot control what genes we get or what genes we pass on. We pass on a lot of really good genes to our children, and sometimes we pass on genes that affect our health in negative ways. And one of those might be a gene associated with Lynch syndrome. Probably there's others as well. We all have many genes that are not working right, that are affecting our health. This is one we can do something about, so that's why we test for it. Despite the logical parts of us not being able to control our genes, people feel guilty, either that they passed something on or that they don't have to deal with something that someone else in their family has to deal with. We call that survivor guilt. There's people that worry about relationships and maybe feeling closer to other people in the family that also have Lynch syndrome, because you've got this connection. Let's go to the meeting together because we both have this. Or feeling, see some audience members. There's also the feeling left out if you're the one that doesn't have it. And how does that impact sibling dynamics as people are growing up? So there's a lot of irrational feelings that come up, but they're very normal and very common feelings. And then when you are delaying the testing, there is kind of that, I keep bringing up uncertainty, but there's also that everyone can be treated the same thought if you've got multiple children in a family. But then there's, how does that change then when you grow up and you find out your status? So there's a lot of different dynamics as people are aging.
Thank you. I from working with many of you, I know that these are things that come up a lot. So I so appreciate your thoughts and your expertise on all of this. Kind of thinking more about talking to children. I know one of the things that we hear a lot from parents is, when do we start thinking about this? When do we start having these conversations? And probably more importantly, how do we talk about these risks? How do you approach this with your families?
So that's a great question I get a lot. And I think part of tying into that question is the issue of when should they get genetic counseling? There's not a bad age for genetic counseling. So testing has got its own layers of issues, but the counseling can happen at any age whenever it's needed. If you're a family that says, I'm fine with waiting till my child's 18, they're fine with waiting till then, we're good, we don't really need anything at this point, then you might not need genetic counseling. But if there's ever questions or concerns, or you're having trouble figuring out how to talk about it, then you've got resources as far as that's concerned. Most questions come up, though, not when you're sitting in front of a genetic counselor. So just like any difficult conversation you would have with your child, think birds and the bees, think, bad habits that people might pick up as they get older. These are all difficult conversations that psychology literature tells us we should take it at the child's level, find out what exactly they're asking, answer their question honestly, normalize these things, and not have it be this big umbrella thing that you're like, oh, I'm holding off to wait to say this. You can give pieces as they get older. It's just a normal part of health as we're getting older. And so usually what I say as far as how to talk to them is figure out what their questions are. If you're feeling like they're not asking questions, but they should know, you can kind of encourage them, be like, have you ever noticed anything different about our family and how often we go to the doctor? And you can kind of err in a little things just to give them some terms that then they might a month, a year later, start picking up on some of those terms and being like, hey, when you mentioned that before, they might have a follow-up question. But it's really taking it at the individual child's level, and developmentally appropriate discussions is usually the recommended approach, to take things one bit at a time.
I'm just going to ask one more question and then we'll open this up, so bear with me. A lot of you who have met with us, we talk about genetic information and how it's protected, the loopholes, things like that. What are the considerations when you're thinking about testing a young, healthy individual?
That's a great question. I think that's part of what factors into that ethical dilemma of why some adults don't want to know their information, and adults can decide, I want to take the risk of having a label of a genetic status. But when we take a healthy individual and we label them with a genetic condition, then we can't really take that away. So if you do test a child, they're labeled with Lynch syndrome if they test positive. So along with that label are concerns about discrimination. So there is a federal law that was passed in 2008, for those of you that are not familiar with GINA. It protects us in health insurance and employment, that it's illegal to discriminate based on someone's genetic status. So they still can discriminate based on family history. They can discriminate if you've had a personal symptom of something. But GINA does not protect against life insurance discrimination. It does not protect against the military from discriminating from an employment status. It doesn't protect anything outside of the two things it does protect. So other kinds of insurances, wellness programs that might offer a discount at your employer. So there's a lot of concern of getting that label because you can't take it away. So that is probably the biggest thing to be aware of from the kind of discrimination standpoint. Right.
Okay, we've been talking a lot, so we want to hear from you guys. We definitely want to have more time for question and answers. Questions?
You covered so much wonderful information. Are these slideshow going to be available for us? Because we couldn't write enough of your information down. And I'm sure if I had that question, somebody else does.
The recordings will be available, like the whole symposium.
Recordings are just your slideshows.
Yeah, so the recordings will be on the website for the,
Perfect.
yeah.
Thank you.
All right. Other questions? All right.
I got a question. My daughter was asking this. She has Lynch syndrome. She's 19, and she had heard about dating. Like, she really probably can't marry somebody who's got Lynch syndrome, or they couldn't have children or something. So she's like, "What am I supposed to do with that?" Like, I go out on a date and then, here, take this test. So, anyway, I don't think she would like me asking this question, but I know she wanted to know the answer. So.
Sorry, Cammie.
Michelle walked away with my microphone. There's a few things to think about. There's the psychological aspect of just identifying that you have extra health risks. If you are trying to date and trying to figure out when do I tell someone that they've got to take me to get a colonoscopy every year. But just really like that there are some higher risks and things to be aware of. And those are difficult conversations for one end as far as how do you talk to somebody. And I encourage reaching out to patient support things and therapy and those kind of things to figure out when do you feel comfortable individually bringing these things up. Sometimes people want to bring it up on the first date. Some people want to get to know somebody first and then bring it up. But I think the other underlying question you're asking is about kind of reproductive risk. And one thing I haven't really touched on a whole lot, but was mentioned a couple times today is the constitutional mismatch repair deficiency, which is when you have the recessive form when two parents both with Lynch syndrome have a child with higher risks. And that is a condition that only happens when it's two of the same genes. So keep in mind, we've been talking about how there's multiple genes that cause Lynch syndrome. If you meet somewhere like today, if your genes are, give you a second, comedic. If your mutations are in different genes, you have a higher chance of getting Lynch syndrome, but we don't tend to see the constitutional deficiency that we would if it was in the same gene. Also, there's options like pre-implantation genetic testing where you can do in vitro fertilization and you could test the embryos to see how many of the mutations are passed on in each embryo. You could use an egg or a sperm donor, adopt. You could choose to have the risk of having a child with one of these conditions. And just thinking about all these amazing talks you've been listening to, by the time a child born today is at higher risk, there's a lot more options that are going to be available for dealing with the health risks. So there's a lot of different choices that are available as far as the reproduction is concerned that I would encourage each individual to talk to their providers about. But yeah, it can be a difficult conversation to figure out when in dating it makes sense to bring it up.
Yes, my question is around the privacy around the information itself. If your child or even myself gets checked for the gene, how does the insurance companies and everybody else find out about it? Is that information like HIPAA's doesn't cover that, or if you could go into that, that'd be helpful.
Yeah, so there's different laws that address privacy. So obviously HIPAA does protect privacy. You can't just go in and to someone's records, but you also can't lie. Like if you're filling out a life insurance application and they ask, have you had genetic testing? You have to say yes if you have. And if they say, what were the results? You kind of have to be honest about that. And life insurance companies, for example, are getting savvier about asking those kinds of things. If they don't ask, you don't have to tell them. So, you can, if you're considering testing a young person, whether that's a minor or a young adult who's perfectly healthy. Otherwise, you can either get life insurance in place before doing genetic testing, so you don't have to worry about that question, or you can look for a provider that doesn't ask that question. So hopefully that answers your question. So the privacy is like a separate set of protections, but I think how are we doing on time? Okay.
I'm going to piggyback on his question and just say my children are 28 and 30. I am positive for Lynch. They need to be tested. They need life insurance. They will get life insurance before they're tested. But what is the possibility of life insurance coming back after, say, one of them does develop or is tested positive for Lynch? They already have their life insurance in place. Like, am I going to have to jump through hoops with them to get life insurance for them?
So my disclaimer is I'm a genetic counselor, not an insurance broker. However, you are an insurance broker. All right, tell me if I'm right or wrong on this, that most life insurance policies, once you sign them, depending on the type of policy, can't be changed later. Is that true or not true?
So each state regulates insurance. In the state of Colorado, there's three ways to cancel a life insurance policy. One is non-payment of premium. The second is suicide in the first 12 months. If someone commits suicide in the first 12 months, there's no coverage. And then the third is contestability, which is a 2-year look-back period. So if in fact the applicant were to die in the first 2 years, they could contest the application. If the application did not mention a condition that they knew of during application, then you could get their premium back, but you will not get your death benefit. So our son got life insurance before he got tested. So that, as you mentioned, I think is a smart move. I do not, but I think you can call each state's division of insurance, and they'll have people there that should be able to answer that question for you.
I am more than happy to answer additional questions anytime. So feel free to reach out if you're concerned about your children or grandchildren or other children you know at risk for Lynch syndrome.
And one thing, just before we close, that I so appreciate you mentioning this, Cammie, but I think it's really important to remember, we talk about testing, when are they ready to test? But I think as Cammie pointed out, that genetic counseling can come way before that. Kids are so much smarter than we realize. For any of us who have kids, oh my God, they know way more than we realize as parents. And so, I think if they start asking those questions and, maybe they're in middle school and they're getting some introductory genetics, it might be the right time to just have a genetic counseling visit where it's, just information giving, and there's no pressure, there's no expectations, but really just learning more, because ultimately, whenever genetic testing is done, we just want to make sure that there's informed consent. That is really the biggest thing, that individuals are making a decision based on educated, informed material. So are we out of time?
It's perfect. Yep.
All right. Thank you.
You all.